For who is this one? Namela ka mo. O potologile gole. O potologile ko gole man. E theoha mo. Okay. Yeah. O mong kae? I don't know. Yere ke ba isetso. Engwe ke eo ya bereka. Alright, le kae? Ya o fa batho ba le ba emisitseng matsogo, batho ba ba staraga. Ka mo ba covered. O sota ko morago kwa. Batho ba ba staraga bjang. Ba latela. It's give and pass. Are they covered? If we were waiting for this lady up there, we were going to be very late. Hello.
That lady will answer that.
Hello. Hello. The distributors are very slowly. You are very slow. Just hand and pass, please. How many are still outstanding? Ba o fitile wena. Wa emisa letsogo. Ke neng ke fa di Go and collect it there, please. Because I was given this side. Can we settle? We are starting now. Can we settle? Okay, come on. Hello? Phaladi-Digamela. Can we keep quiet, please? Hello? Please distribute gadgets silently. We've given you enough time, but you are not finishing. Hello? My name is Phaladi-Digamela. I am the chairperson of the Health Portfolio Committee in Gauteng. If you like, you can say Dr. Digamela. I also appreciate that. Can we keep quiet, please? I am with a member, Litie. She's also a member of the Health Portfolio Committee in Gauteng. I'll ask her to wave. Thank you very much. And I'm also here today with Honorable Baha from Parliament, NCOP. He is a permanent delegate for Gauteng, representing us in Parliament. Please wave, sir. Thank you very much. I am also here today with Mr. Piti, Chief Director for Health in Tshwane from Gauteng. Please wave, sir. I am also here today with Dr. Chikovo, who's also going to do a presentation for us this morning. Thank you, sir. Mr. Piti will also do a presentation on behalf of our Gauteng province. In your midst, we've got Professor Crisp, who is involved in ensuring that this, what we are here, we are doing it the right way. Prof, can you please wave? How? Clap hands for Prof. It's not easy to become a prof. I'm prof in making also. We also are having Mr. Eugene Mahletla from World Health Organization. Please wave and stand and show people that we've got the global body here today. Where is Mr. Mahletla? Oh, he is at the back. I don't know. You can't lead from behind. Leaders always lead from the front. Here, there are seats for people like you. I can't see you from that far. Also, we are having the ward councillor of Ward 3, Councillor Malisela. Where is he? Oh, there is the councillor. You can't lead from behind. You lead from the front. There are chairs here, I think they are dedicated for yourself. We've got Councillor of Ward 71, Councillor Pasha. There are chairs for yourselves, they are here. You can clap hands for your public representatives that are representing issues in the community. From the committee side, I am having Dr. Mukonoto, who is the researcher for the community. Can you please wave? Yes, we also are having Nokwasi Nkiti, Senior Coordinator for the committee. There he is. We also are having Non-Dumiso Nkiti, Non-Dumiso August, who is also from the committee. And then we have others, they are still busy sorting out registration. We've got Isaac, we've got Wakile, and service coordinators, and we've got Musima, who is also a legal person for us here. Can you wave? Yeah, so today we are here so that we give the population of Tshwane opportunity to have inputs and say towards the national health insurance. So without any waste of time, because we were delayed by when you were still coming, we've been here since 10 or 9:30. All of us. Now, those who received this, channel 1 is English. If you press, there is 0, there is 1, there is 2, there is 3. I think there will also be 4. On channel 1 is English. Sesotho, Setswana, and Sepedi is channel 3. Sesotho, Setswana, Sepedi le tla di hwetša ko channel 3. Sekgowa sa Maisman ke channel 1. isiZulu, isiNdebele neXhosa channel 4. Tobetsa ga o tobetsa o tla bona go tla tlhagella 4 mo. Ya ka no ke 0 ke 0. And then Afrikaans is channel 2. If you want to listen in Afrikaans, you go to channel 2. Tshivenda and Xitsonga, you go to channel 5. Ke bušeletše. Sekgowa, Senyese, sa Maisman, channel 1. Sesotho, Setswana, Sepedi, channel 3. isiZulu, isiNdebele, uzosithola ku channel 4. including isiXhosa and isiZulu, yes. Then neSwati sikhona lapho. Afrikaans channel 2. Tshivenda and Xitsonga channel 5. Renali sign language also, ne? Yeah, sign language will show on more screening. So ke a leboga. You are all welcome to this meeting. Can we please keep quiet and listen when the presentation is taking place? Let's not make noise so that we are able to hear what they are saying. These gadgets belong to here. Adibereki outside this place. Ibile dinale tracker. Ne? Don't invite problem unnecessarily. There is a tracker on each one. Adibereki ko hae dibereka ka mo fela ne? Yeah, when you leave it here. Don't take it out, please. There is also Dr. Dinweli, a senior researcher for the committee. I don't see him here, but she was around. There is Wakile, please wave a hand. He's an information officer for the committee. There is AB communication officer. Can you wave? AB Mukoka. So the committee is well covered when they came here. No, so the agenda, I think you have seen it in your package that they gave you when you came in. Opening and welcome. I welcome you all. Feel free, and then I think when you register, they would have shown you the bathroom di go kae. So the agenda is item 1, 2, 3, 4, 5, 6, 7, 8. Everyone is having the agenda. Honorable Litie, can you please help us to adopt the agenda?
I move, Chair, for the adoption of the agenda, or second,
Thank
because
you.
you would have moved. Thank you.
Thank you very much. We don't have any apologies for those who are not with us, so we are passing that one. And then introductions I've already done. You have seen who is here. Then now, item 5, I'm now handing over to Mr. Piti, who will present shortly on behalf of Gauteng Province. Then I will introduce Ms. Dr. Chikobo to also speak. And the other thing, what I need to do, this venue, here where we are, is taken to be the venue of Gauteng Provincial Legislature according to Rule 56, subsection 1 and subsection 2. Whatever we are doing here today, we are Gauteng Legislature. We are not only doing things out of our own. Everything we do, we are protected by the Gauteng Legislature. Thank you very much. I'm now handing over to Mr. Piti on behalf of Gauteng to do a presentation about national health insurance. I advise you to take notes so that when it's time for questions, I'm going to note you and then you can make your comments and questions, and then they're going to respond. Over to you, Mr. Piti. Thank you.
Thank you, Chairperson. Honorable members, distinguished guests, members of the public, all protocol observed, good morning. I'll briefly go through the presentation from the Gauteng Department of Health and Wellness in terms of NHI. Basically, national health insurance, what we refer to as NHI in short, aims to achieve universal health coverage for all South Africans. Now, every person will get the health care they need when they need it, where they need it, without financial hardship. And NHI is a health financing system that is designed to pool funds together to provide access to quality, affordable personal health services for all South Africans based on their health needs, irrespective of their socioeconomic status. Now, this is a process that we have gone through in terms of getting to where we are now. There was a green paper established in 2011 where government discussions started, and it gives ideas on thinking about a policy. In 2015, a white paper was developed, which is a broad statement of government policy drafted by the department or a team. And then phase 2, which was part of this process, which is 2012 to 2017. Now, in 2017, there was NHI policy developed, which identifies the actual principles or what is to be done. Then 2018, a national health insurance bill was drafted, which is a draft of the law that needs public consultation process. In 2019, there was public consultation process, which continued after reviews and inputs, and this was a process led by the NCOP. And now, today, we are in 2023, and we have this bill that is being consulted on, which is a process led by provincial governments in each of the 9 provinces. And today we are here as part of that process for Gauteng. Then beyond this, 2023 to 2030, it is expected that the NHI Act will then be passed by the National Assembly and then signed off by the President as the law for implementation. Now, why do we need NHI? Healthcare is a human right that every one of us is entitled to. And I think this is a widely accepted international principle, and this should not be dependent on one socioeconomic status or financial status. Presently, we have a totally inadequate 2-tier health system with poor outputs or outcomes in comparison to the inputs that we give as a country. We have a fragmented, poor, inefficient, understaffed and ill-equipped public sector serving about 85% of the population, and a fragmented, over-serviced, over-specialized, expensive, and private sector serving about 15% of the population. So it is not possible to address one part of the dichotomy without addressing the other, as the two tiers are mutually dependent. Now, we need a facelift for the whole national health system for us to achieve what is desired for the population of this country. Now, the NHI fund will NHI will pool public resources into one fund, and the NHI fund will purchase services, or what might be referred to as benefits, on behalf of the whole nation, from both the public and the private health sectors. And the NHI fund will contract directly with the service providers to provide those benefits that have been identified from these service providers. The public must register with clinics or a family practice or a GP practice next to where they stay to obtain these services. Now, I've spoken about the implementation process towards NHI, and I don't want to repeat this. Basically, this shows the split in funds that are available in the country in terms of the public sector and the private sector. And if you look at the total spend in the public sector for health services across different departments, you'll see that it is about 265 billion, which serves 85% of the population. And if you look at the private sector, it's a similar split. It's 277 billion that is spent or provide services for 15% of the population. And that is why we need this process then to make sure that we pull all these resources together so that we can provide services equally to all South Africans. Now, what does the NHI bill say? The enactment of the NHI bill will change the way all healthcare services is paid for, introduce a single national pool of health funds, establish a single purchaser to manage these funds across the country. Now, the NHI fund will purchase primary healthcare services from both the public and private sector through contracting units for primary health care with this, through a risk-adjusted capitation. And I suppose Dr. Chigov, when he presents, he'll touch on some of these things. Now, as part of this process, each province has been given an opportunity to test proof of concept in terms of contracting units for primary health care to see how this is going to work in reality. And for Gauteng, Sub-District D in Johannesburg District has been chosen for that purpose. But because it is too big a sub-district, Sub-District D is the whole of Soweto. So it has been brought down to a specific area around the Tshwane Community Health Centre, including the Bheki Mlangeni District Hospital, to look at this concept. Now, hospital care will be also directly from accredited public and private providers, and not through the provincial departments of health. Sorry. I forgot that these gadgets always create problems for us. Now, this process will radically change the way services are provided, as central hospitals will become components of the national government. Now, the central hospitals is what possibly you know as academic hospitals, and we have 4 of them in Gauteng. That is Chris Hani Baragwanath, Charlotte Majeke Academic, Dr. George Mukari, as well as Steve Biko Academic Hospitals. Then all public and private providers must be certified by the Office of Health Standards Compliance before they can participate with the NHI fund. Now, failure to comply means that there will be no statutory way to pay for the services rendered by those that are not duly certified. Now, NHI primary healthcare priorities in terms of addressing primary healthcare infrastructure and service details, there needs to be understanding of the catchment and clinic usage, that is delimitation of catchments by geographical area. And currently we work in terms of sub-districts. In Gauteng we have 5 districts, is the 3 metros and the 2 district council, that is West Rand and Sedibeng. The 3 metros is Johannesburg, Ekurhuleni and Tshwane. And now in each of the 3 metros, there are administrative demarcations. And in Tshwane, you all know we have what the city refers to as 7 regions. Now those 7 regions in terms of health language are sub-districts. So there will be that kind of delineation in terms of this process. Now for contracting units for primary health care, it may be either at the level of a sub-district or the sub-district may be broken down further in terms of the complexities in each of the sub-districts as I've outlined with regards to sub-district D in Johannesburg. Now there'll be profiling of the private sector to address deficit areas. That is, what are the gaps on the service platform in terms of both the public and private health service providers. The provincial departments of health will have a stewardship role that though they account for the public sector, they'll be responsible for what the private sector is also doing in the province, as well as harmonizing the 2 service providers, assess the effectiveness of the current referral system, and put in place remedial actions to ensure that patients are able to access all levels of care they need at the appropriate places in terms with the accreditation and certification processes. Then we would also cost and identify funding sources for the comprehensive introduction of e-health solutions within the province. That is, try and digitize the whole health service delivery system. And we have seen already when we are managing COVID that we are able to come up with a system that is able to record all our affected and infected members of community through one electronic system to be able to respond accordingly. And we want that to work as for the whole national health service, both public and private sector, going forward. Now we need to also look at the issues of capacity in our health facilities and optimize the skills mix to ensure that we have appropriate skills at appropriate level in terms of the disease profiles that we'll be responding to in the different areas. We currently have district management teams in each of the districts that we have, and this will be configured as we move forward to become district health management offices that will be responsible for services in each specific district. There'll be projected costs of implementing the purchaser provider functions and the processes and procedures for accreditation and the system for monitoring standards that were also being considered. Now, I've already spoken about the proof of concept that is being implemented in Sub-District G in Johannesburg. Now, the District Health Management Office will be a component of the national government, but can be delegated to the province, and it will have more authority than the current district offices. The contracting unit for primary health care will be a geographical area around a district office, and I've outlined this in terms of the sub-districts and further delimitations within the sub-districts in accordance with what is required. Now, the NHI bill, once promulgated, will become an act in addition to the National Health Act and will not repeal the National Health Act, though there will be some amendments to the National Health Act to effect the changes that we're looking at. The role of municipalities remains unaffected in terms of delivering non-personal health services or what we refer to as municipal health services currently. And Schedule 1 of at the end of the NHI bill lists the amendments to previous pieces of the NHI National Health Act, which will be concurrent with the passage of the NHI bill. Now, in terms of district readiness and external assessment processes, I've already touched on some of these issues as I was presenting. The Office of Health Standard Compliance assesses health facilities for purposes of certification, and Gauteng has had 36 primary health care facilities and community health centers already assessed and certified as ready. And then the first cohort was 16, and they were certified until 2024, and the second cohort of 20 certified until 2025, which brings the total to 36. Now, internal processes of attained ideal clinic status are continuing to be done throughout our health facilities as a support to the external certification process. In terms of hospital readiness, all levels of hospitals are undergoing pilot stages of preparedness through a process of health assessment, which is done through attaining the ideal hospital status. This is an internal process also that is done to prepare hospitals for external assessment by the Office of Health Standard Compliance. Now, these assessments are done continually, and the norm is that the Provincial Quality Assurance Team conduct a status confirmation assessment to verify that the facility has indeed achieved the status as indicated. Now, those that did not achieve the status undergo a process of intense quality improvement plans and reassessment to ensure that they are ready. And I can indicate that currently in Tshwane, we have 4 hospitals that have been certified by the Office of Health Standard Compliance as being ready. Then in terms of the transitional arrangements of the bill, these are the issues outlined in terms of Section 7.2d. A user must first access health services at primary health care level as entry into the health system, and I've already indicated that we need to register the nearest clinic or a GP or family practice next to where you stay. Then we must also adhere to referral pathways for health care service providers or health establishment. We want to be able to go anywhere we want to go for each kind of service that we need. You first start at the clinic, or the local GP or family practice where you stay, and you'll be duly referred if you need further treatment elsewhere. Now, these are a list of key referral issues that have been considered. And then in terms of getting us ready for this process, I've spoken about the organizational structure in terms of the District Health Management Office and proof of concept for contracting units for primary health care. Then there's a delegations framework in terms of refining how reporting will work and what authority and powers will be delegated to the local level in terms of the district health management offices. There's collaboration with the private sector, and we're also leveraging the MOUs that we had in management of COVID-19 that I've already alluded to. Then in terms of the changes at central hospitals is what I've indicated already, and we don't have to repeat that. Now, it is expected that we need to have cost centers at every level of the service. A cost center might be a GP practice, a clinic, and in terms of hospital, it can be certain units inside the hospital that become certain cost centers in terms of ensuring that there's equitable allocation of resources and efficiency in terms of utilization of those resources. Now, there will be functional business units that will be put in place, and these are important, that whether we have NHI or not, this is an important component of work that needs to be done to improve on the efficiencies in the way we provide services and patient care across the organization. Now, key lessons in terms of this process is that there's need to invest in social participation and citizen ownership as the cornerstone of the health system transformation process. And I suppose this is part of that consultative process, and this participation will carry on through different mechanisms also as we move forward through our governance structures that we have at the clinic level. In terms of clinic committees, we also have hospital boards that are meant to help with interaction between the department and the community. We need to build a strong primary health care system with a strong health promotion and prevention focus, because if the population is healthy, then the expenditure on managing diseases will be very limited. So to sustain our resources, we need to have a very strong health promotion and disease prevention program. Then we need to implement strong governance structures for strategic purchasing of appropriate interventions for population health outcomes, invest in and build strong health intelligence and policy evidence generation capabilities, which means that there must be a strong research component that goes with this process, that we have evidence-based information to help us with decision-making. Leverage potential technologies to strengthen the healthcare system, and then invest in a strong capability development and mentorship program of young professionals in this regard. Now, in conclusion, NHI is for everyone. Universal health coverage can be achieved if current resources are better utilized. New models for service delivery will be required. NHI will provide financial protection for all from the cost of health care. NHI will purchase services from both the public and private health care providers. New methods of paying for services will be tested and implemented. People who wish to purchase care not provided by NHI will be able to do so, and institutional and administrative changes will evolve. This is not an event. Thank you very much.
Thank you very much, Mr. Pitsi, for that presentation. Let me say all health professionals from Gauteng Department of Health and from the National Department of Health, you are all welcomed. I see you, Dr. Litebele, you are here. Also, Tebogo Ranaka from our legislature representing COP, you are also welcomed. Earlier on, I said Councillor Pasha, but I didn't see him waving a hand to greet the Chabakam. Please wave your hand wherever. Yes, there is the Councillor Pasha. Without any waste of time, I'm now handing over to Dr. Chikovo to also give us a presentation. Please continue writing notes or areas you need clarity. They are going to give you responses. And I'm handing now over to Dr. Chikovo. Please, the space is yours, sir.
Good morning, Chairperson and members of the committee, and good morning to all of us. Thank you very much, Chairperson, for this opportunity. As you have indicated, my name is Adiel Chikovu. Mine is a very, very simple task, Chairperson. It's to make the bill talk to us. That's all I have to do, to make the bill talk to us. Well, there are so many versions and interpretations, some of which are far divorced from the bill. But the purpose for this particular event is simply to say this is what the bill says. Here and there, obviously, I'll be able to qualify and explain it. And thereafter, of course, people can simply also make up their minds. But it's important that as we do so, we have a very clear, concise understanding of the bill and its implications, what it seeks to achieve, etc., and do it in this particular fora. So thank you very much, Chair, and your committee for this opportunity and privilege. Chair, I noticed you did acknowledge the presence of Prof. Nicholas Crispy, but I really want to reiterate as well as acknowledge him together with his team. I think there are there 4 or 5 of them from National Department of Health. I say so because they've been instrumental in the presentation and as well as the drafting of the bill. So thank you very much, colleagues. And if there's a contradiction between what I'm going to say and what they then say after me, just to know, Chairperson, they will be correct and I'll be wrong. So we start with the bill. Now, one of the slides that Mr. Piti shared said something like the NHI will not repeal the National Health Act, because in South Africa, services are run and configured by the National Health Act. So already we begin to see, Chairperson, that therefore the notion that the NHI seeks to nationalize healthcare services cannot be correct, for as long as the NHI does not set aside in its entirety the National Health Act. So it's important that we start from that perspective, and then we also look at the essence of the bill. So you can see that the bill establishes the NHI fund as a legally defined organ of state. I have no intention of reading this one by one. No, I just want to explain and highlight a few issues and in part also respond to the debate that we often see in the public domain. But I must indicate, Chairperson, I'm completely neutral as I do that. I'm just interpreting the bill and the essence. So I've already indicated it seeks to establish the National Health Insurance Fund in South Africa. And then it gets into the functions, the powers, and the duties of that fund. It seeks to provide the control of the fund. Now, the other things that you will see on this slide, these are words that I'm actually taking from the slides. The bill seeks to define beneficiaries of services. Another point, the bill also provides for the contracting of accredited providers. And then the last point, it speaks about the bill coming up with a mechanism to reimburse through the fund. So the fund will actually be reimbursing for services, healthcare services that are being purchased from providers. And so there will be providers, then there will be the fund itself. So this is part of what is often referred to as the purchaser-provider split. So the NHI fund, its core mandate becomes to purchase. Then we have got providers, the provinces, the public, the private, GPs, etc., all those that will constitute the pool of providers of healthcare services. So again, Chairperson, if someone says the bill seeks to do away with the private industry in South Africa, clearly they've not read the bill, because the bill actually says the fund will be purchasing from both public as well as private providers. So the bill consists of 11 chapters, and you can see them there, Chairperson. There is part 1, part 2, then part 3 is dedicated to the fund. It also speaks in terms of governance, how the governance will play out. So we have, for instance, part 4 speaks of the board. Part 5 is the chief executive officer, etc. We have got advisory committees. There is also a very, very important section, which is part 9, complaints and appeals. Then there are issues pertaining to financial matters as well as miscellaneous. So it's quite extensive. Having said that, often people ask a lot of implementational questions, and I just want to point out that the bill is a bill. It's not an implementation plan. So it may not consist and have all the technical details, all the answers to the questions that we want to ask, especially at a technical level. Do remember, it's simply a bill. It gives the framework, it gives the strategy, it gives an indication of how things will play out. Thereafter, if adopted, there must then come into play other plans that are much more specific and technical in nature, etc. Right. Then we proceed in terms of the purpose of the Act. So I think I've already spoken as far as the purpose of the Act is concerned. The application of the Act, there we have it. So this will apply to all health establishments, excluding obviously military health services and state security, etc., because normally those are actually covered under different provisions of the law. In terms of the population coverage, there are fears that if we go the NHI route, everyone, the whole of Africa, will invade and utilize services, etc., and people cite number of instances such as what we saw on TV in Limpopo, etc. But I'm glad, Chairperson, to simply indicate that the bill has already taken all that into account. So there's a population coverage. It defines who will benefit from the services that we have as a country. And this is just an indication. So the fund will purchase services on behalf of South African citizens and permanent residents, asylum seekers, and illegal foreigners. They do qualify for a certain package which is defined, as you can see there, emergent services, notifiable conditions, basic health services, etc. There is care for all children, and then anyone else coming into South Africa. And we see this is not a new thing, Chairperson. If you go to other countries, the first thing that they actually ask ahead of the visa is the travel insurance. So that provision has been catered for in the bill. Anyone coming into this country will then be required to have a travel insurance. And what that simply says, Chairperson, is that therefore the fund, the NHI bill, seeks to protect those resources. They are not being opened up to every Tom and Dick and whoever wants to utilize resources, but they are actually being ring-fenced, and people will have to use as defined by the Act. Then there is the registration of users. I think I won't waste a lot of time on that one, because Mr. Pitsi did indicate what will actually happen, that people will have to start at the lowest point of entry, and that will actually be your nominated GP. It might be a clinic, it might be a CHC, etc. But the choice is yours. So people are not being forced to go to a particular place or area to seek services. The choice still remains yours according to the provisions that are there in the bill. You will nominate your lowest entry point. The bill also speaks about what happens under emergency. So in emergency, of course, you'll be taken to the nearest health service provider, where you are then stabilized and before being escalated elsewhere. So all escalations will also happen within the context of the bill. And it's very, very important, Chairperson, because I think, especially for some of us who are in that space, we believe this will be a game changer. Because in South Africa as a country, a lot of people often bypass primary health care. And that inverted triangle sometimes is not sustainable, both financially as well as in terms of the impact and disease profiles, etc. So the bill provides an opportunity for people to actually start at the lowest entry point, and then they are escalated within the system. Right. So looking at access to healthcare services, so if that is achieved, Chairperson, the quality of healthcare services, we really believe they will see an improvement. But key to that is the fact that one of the biggest issues that is being addressed is the fact that you must receive the healthcare service that you need based on need, not on the strength of your pocket and ability to pay for it. And that is a key requirement. I think Mr. Pitsi did speak about that. So quality healthcare services that will actually be free at the point of care. I'll skip other things. To purchase healthcare services that are not covered by the fund through a complementary voluntary medical insurance scheme. Again, that was a point that came from Mr. Pitsi's presentation. So people will not be confined, because there's also a narrative that NHI seeks to confine me. NHI seeks to prescribe to me what should happen. No, people will still be able to get their own medical insurance cover. But of course, the difference being that because medical tax credits will be removed, all that you'll have then to do out of your pockets. But it also points to a very, very important issue regarding those who say the bill is seeking to remove medical aids. They are already there in the bill. They are being acknowledged. So the bill does not seek to remove medical aid from anyone. It doesn't. Right. So again, looking at access, the fund must, is this, am I here? Sorry, I'm just want to check. Yeah. So the fund must purchase services on behalf of all beneficiaries. So if a person chooses not to use the NHI route, it does not mean you'll be refused treatment or you'll be turned away treatment. It simply means you are now on your own. You are paying for it on your own. Anyone who seeks to benefit from the NHI must follow and be part of the system. And that is actually an elaboration on the point that is being made, that the fund will then purchase services on behalf of all beneficiaries. As long as you want to benefit and use the fund, then you need to follow the system. I'm just looking at key points, Chairperson, in the interest of time. Users must enter the PHC level and follow referral pathways as a condition of entitlement. I think we spoke about that. The other point that we have there is that cost coverage free at the point of care. I keep on reiterating it because it is key to the thrust of what we want to achieve as far as NHI is concerned. It's about removing any hurdles. It's about removing anything that would prevent you from accessing healthcare services when in fact you need them. And as I've indicated, key to that is the fact that it should not be financial hardships. So the services will obviously be free at the point of care, and that's a key issue. Right. Then again, we are looking at the establishment of the fund. It's going to be a Section 3A public entity. Now that's very, very important. Sometimes we often see, especially on TV, people who say the state or the government or the party or whatever it is, they have never run anything successfully, and they cite illustrations of ESCOM, etc., etc. Now, I'm saying this just to show you that next time when you hear that, or if you want to do it, please compare apples with apples, because the fund is going to be a Schedule 3A public entity. ESCOM, by its operational modalities, is expected to make a profit. That is not the essence with the NHI fund. A Schedule 3A state entity, I can speak of, for instance, your Council for Medical Schemes, that's a Schedule 3A state entity. And government has been running quite a number of those very, very successfully, some of them with clean audits throughout. Then we go on to functions of the fund, Chairperson. I think what I just want to reiterate without reading all those points is something that I've already indicated earlier on. The function of the fund is to purchase healthcare services from service providers. The functions of the fund is not to run healthcare services. So already, people who speak of excess cost growth, we need 583 billion to run NHI. They are assuming that the fund is going to run healthcare services in South Africa. Please, it's not so. These are not my words. They are there on the bill. The fund, its main job is simply to purchase or pay for healthcare services that have been delivered to you. It won't be running healthcare services. So it's important, Chairperson, that we understand. And of course, there are several other bullets below there that actually give precedence to this point. Then we go on to powers of the fund. Quite a number of them. I think I'll just look at the middle one. It says implementation of best practice in terms of purchasing of services, procurement of goods, efficient delivery of healthcare services, data collection and analysis, fraud prevention. So those are necessary because the reality of it is, yes, as a country we have seen the ugly side of what happens as a result of corruption and misgovernance. No one can turn a blind eye on that. So mechanisms are being built, and the fund, the bill already establishes the risk and fraud matrix and prevention and how all those will help insulate. Now, if you are going to quote me, I'm not saying there won't be any fraud and what, but I'm saying maximum care has been built inside the bill to mitigate against such eventualities. And the last point there, very, very important, negotiate lowest possible prices for services and goods. And one of the reasons why the bill was drafted in this manner, it was not, I want to repeat again, it was not to nationalize healthcare in South Africa, but it was merely to maximize on economies of scale. So the fund is then expected, number one, to purchase all services. Number two, to, using the economies of scale, negotiate the lowest possible prices for services and goods. Then we have got the establishment of the board. Chairperson, this one I'm going to skip in the interest of time, but I'm just showing you the thorough work that has gone into ensuring that every single element of governance is also taken into account. The constitution and composition of the board, and after due consideration, Chairperson, and submissions that were made, especially, remember, we also had sessions in 2019, there have been amendments and alterations, there were concerns about the minister having so much power, etc. And all those have been listened to and taken into account, and some of them factored to produce the bill, which was recently adopted by both the Portfolio Health Committee in Parliament as well as the National Assembly. Then we have the chairperson and deputy chairperson of the bill. Now you can see that the minister will only have an obligation to appoint one of them, but not the other. Then we have the functions and powers of the board, conduct and disclosure of interest, procedures, remuneration and reimbursement, etc. All those are normal governance instruments that are used in such a big entity. And all we are trying to say, Chairperson, is a lot of work has gone to knit this as much as possible. And yes, we concede it may not be perfect. It will always be continuous work in progress, refinement after refinement. Then these are the obligations of the Chief Executive Officer. I'll skip those. Then we've got the Committee of Board, technical committees. So I just want to indicate there are quite a number of technical committees, and this gives us comfort because we know for sure that it's not the minister doing willy-nilly pressing a button and deciding, okay, so we are going to have this and it's going to play out this way. The bill actually sets out committees that will advise and guide ministerial decisions as they are made. For instance, you have got the Benefits Advisory Committee, and you have got the Healthcare Benefits Pricing Committee, And some of the members that are already steering and running with these committees are here. I think some of them will even speak or introduce themselves later on. You have got the Stakeholder Advisory Committee, and also the bill then goes on to specify the function and the role of the minister in relation also to those committees. Then there is the role of the department, the national implications on the National Health Act and the Constitution. So I've already explained, Chairperson, the fact that healthcare services in South Africa will continue to be run by the National Health Act. However, where there is a conflict with the NHI bill, which is the financing mechanism, will supersede the National Health Act. But the two are actually complementing one another, and that is very, very important. Then, role of provinces under NHI. I think the key issue, Mr. Pitti spoke about it already, is the stewardship role that will come to the provinces, the executive authority, where they are now expected, obviously, to take custody of the outputs and the impact within both sectors, the private as well as the public sector. And I think point number 10 and point number 11 are also very good for us to highlight. Promote health and health lifestyles, which is a big focus towards prevention and awareness as part of the provinces. These are things that we already do, but we are saying the bill actually wants us to do a lot more than that we currently do, because as we know, prevention is always better than cure. And generally in South Africa, we are a very hospice-centric society. Provide environmental pollution and control services. I think some of you may have seen, it's been all over the news on TV, etc. Children who ate food which was not properly prepared, etc., and sadly passed away. So the point is the bill has really, really dealt with a lot of issues that we face as a society. I think I'm about to conclude, Chair. The role of medical schemes, I think I've explained that. They will continue to exist, but there won't be any medical aid credits, because those will be directed towards the fund. So there is no intention, and it was never an intention of the NHI bill or the drafters or government to abolish and do away with medical aid. It will still be there for you to choose as you so wish, provided, of course, you can afford it, because then what you were previously being subsidized on will, in fact, fall away. The DHMO, Mr. Pitti spoke a lot about that. I think when one looks at the bill, this is not in the bill, but it's me. So if you quote this part, you must say ADL said, don't say the bill says. But when one looks at the obligations under the DHMO, we really believe it's going to align more or less to the President's district development model. And you can see in terms of the expansion of services as well as skills competency that it must now address and articulate. Contracting units, I was going to talk a lot about that, but just to indicate, contracting units will now be no longer a part of what is under the DHMO, but a competency under the fund. So the contracting units, those are the administrative units looking at the purchasing of primary healthcare services. So those will actually fall under the fund, and we are still awaiting further details as far as the modalities of those are concerned. The other one is the health products procurement unit. This will in fact be responsible for those of us who are in departments of health. Some of us, we have what we refer to as the MSD, Medical Supplies Depot. Almost everything that it does will now be a centralized function falling under the health products procurement unit, and it will be in charge of centralized facilitation and coordination of procurement of health goods, among other functions. Right, accreditation of service providers. So I think we have all seen this scenario of TikTok doctors, TikTok nurses, TikTok this and that, etc., etc. So for anyone to provide services to be accredited to the fund or to be registered by the fund, there must first of all be certified and accredited by the Office of Health Standards Compliance. So you can see that's a very necessary control measure. And I think recent events have shown us why that is in fact necessary. So in my own view, the bill has actually gone ahead of many other events that we would necessarily have had to respond to, but have now been proactively put and addressed by the bill. Provide maximum range of services, etc., etc. Those are some of the obligations of the fund. Information platform of National Health Insurance Fund. There is also issues around payment of service providers. Now, one of the things that provincial departments of health often struggle with is the payment of service providers. So you can see this is a separate section in the bill, and these payments, especially at PHC level, some of them can even be prospective, some of them can be retrospective. But we really think this will help us move away from passive purchasing, because currently our problems, the reason why suppliers are often not paid, it's because of logistical problems with passive purchasing. The bill comes and introduces what is referred to as strategic purchasing. And in another session, Chair, I'll be very happy to explain it, and the colleagues from National Department of Health can actually elaborate on it because they are running with those concepts. So the idea of strategic purchasing is actually going to be a game changer for both providers as well as purchasers and suppliers of goods and services. Minister to make regulations relating to payment mechanisms. I think Mr. Pitti spoke about that. Then there is the issue on complaints and appeals. I won't go into detail about that, but it shows you that the bill seeks openness and transparency, because this is an acknowledgement that especially as we begin, there may be teething problems, etc., and where the people are not happy or where there's an issue, where there's a problem, there is an entire section that is actually devoted to complaints and appeals. Financial matters, that's a big one, and that's my second from last slide. No, third from last, okay. So in terms of source of funding, because that's always the one that comes up. Even yesterday we were addressing a session and the first question was, where are you guys going to get the money? And we always say, if you go to Pick and Pay today, you put in that shopping basket what you want based on the size of the pocket that you have. So the bill is going to purchase services based on the money that is available. That's the first answer. The second answer is even the current monies that are within the system, they can still be made to follow the NHI route. And that's very, very, very important. And then in terms of the chief source of income, so you'll get appropriations through the Division of Revenue Act in Parliament. Yes, general tax revenue, medical tax credits, I've already spoken about that. I actually want to mention this point because people always say it to say, but it's our medical aid. You guys, you can't do that. It's our medical aid. But did you know that your employer goes and claims medical aid tax rebates from SARS? So the question is, whose money is it really, 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 really? You know, I'll wait for the answer. There are also, the bill speaks of a payroll tax, surcharge on personal income tax, etc. Then the usual governance issues kick in. Your auditors come in. There'll obviously be compliance issues such as annual reports, etc. So all these, they are there in the bill, part of the bill. The bill also speaks about transitional arrangements. There was a presentation from Mr. Msonoki about that. Transitional arrangements, it is what we do in preparation as we begin to approach to the implementation of NHI. And I really want to make this very, very clear, that a lot of what we do in preparation are elements of universal health coverage framework. In other words, even without NHI, for the sake of internal efficiencies, you would still have needed them anyway. The issues that he spoke about, for instance, your cost centers and functional business units, health system strengthening, etc., etc. And when people are doing this, sometimes people say, so there's NHI being implemented. the reality is they would still need to be done anyway, with or without NHI. Infrastructure refurbishment, it still needs to be done, whether we choose the NHI route or not. We still need to ensure that our infrastructure is up and sound and well maintained, etc. And so those are part of the dictates that are contained in transitional arrangements under Chapter 11 on miscellaneous. The last slide, Chair, is the legislative amendments. So there are pieces of legislation that will require to be adjusted in order to accommodate the implementation of the NHI. And I'll give you a very simple illustration. I already spoke about it anyway. When you look at the National Health Act, it had both the purchaser and provider functions under provinces. Now, as we implement the NHI bill, we know that that split has to be made between the purchaser, who is now the fund, and the provider, which is now the provinces. By provinces, I mean all those who are providing services, be they public or private. So such an amendment becomes necessary to cater for that separation. And so all these pieces of legislation, there are probably others as well, would need to be made to align, to be edited, to be adjusted in conformity with the NHI bill. Chairperson, the next 100 slides that I have, I prefer to present them on a different day. For now, I will stop here.
Thank you very much. Your 100 slides. Thank you very much, Dr. Chikobo, for that presentation. I suspect the notes or the comments that they will give. I'm now going to quickly give Professor Crisp to also share with us about the NHI. Please pay more attention as well, so that you understand why NHI is important. Over to you, Prof.
Good morning, Honourable Chair.
Prof, before you proceed, can I also recognize the presence of Dr. Tulare in our midst? You can wave your hand, Doctor. And also, there is also Councillor Mpoliwele. Please wave to the community here. Is your stakeholder also? I don't see a hand. Is he in the house or he's gone out? Okay, we will also acknowledge him when he comes. Over to you, Prof.
Thank you very much, Honourable Chair, Honourable Bacher, other Honourable Councillors and members of the Provincial Legislature, and to my colleagues from Gauteng, National Department, all of you from the communities around here, media, thank you very much. I was not intending to speak today, so I really just wanted to listen and participate, but this is a great turnout and nice to see you here. Look, we all understand that healthcare is an emotive matter, because we're all affected one way or another by our health care. But the important thing is that we are all equal before the law. We are all equal in terms of what we need to survive, to live, to thrive, to contribute to society, our families, and the economy. And if we are not able to access health care and be healthy, then we can't do those things. And the problem is that we have an extremely unequal society. So what we are trying to achieve is in healthcare, which is the piece that we are responsible for as health practitioners and as a department, we are trying to move towards the United Nations goal that we have signed to achieve universal health coverage. Now, the previous presentations already referred to that. Mr. Pitsi spoke about universal health coverage being that we want to get the health care that we need, when we need it, where we need it, without incurring financial hardship. Now, many of us, most of us, are able to access health care eventually, but sometimes it's very late. Sometimes our health conditions have deteriorated. And for many, both in the middle class, even some fairly wealthy people, but especially for poor people, we are incurring financial hardship. What that means is, by the time you have to pay to get to the healthcare services, it has cost you so much in taxi fare, in somebody looking after your child, in traveling to look after your children in hospital, in having to spend time away from work, and in some instances having to pay out of your pocket beyond what you are able to pay for. And so people don't go to the health services because it has become so difficult. And that applies to many in both the public and the private healthcare. So what the NHI bill is trying to do is to put a framework in place, and you heard Dr. Chikovu talking about this is a framework. It is not the actual detailed nuts and bolts of you will go on Monday and I will go on Friday and this will happen in the weekend and so on. Those details are still part of the services. So whether you go to a public clinic, if it's a municipal or a provincial clinic, whether you go to the private sector, whether you're admitted in a public or a private hospital, the people who actually run those services must run them. That's not the job of the fund. But what the fund must do is pay the people in a way that is efficient. And that's the problem with our current system. We spend too much in paying for administration. We have developed a system which has got worse over time in the private sector, becoming very specialized when the general practitioner or the nurse could have looked after our condition. And we have developed over time a complicated public health system that has got 9 different provinces, each repeating what the other one's already done. And for those of you who live near boundaries or have homes elsewhere or visit your family, you live in another province, you work in Gauteng and so forth, it's become difficult because the budget is allocated to the province where you live. That's where you were counted in the census. And so people get very possessive of their budgets. So what the bill is aiming to do is to pool the money. You heard the presentations both of Mr. Pitsi and of Dr. Chikovu saying the aim of the fund is to have one fund. Now people think that that is going to be a big bank account with lots of money. That's not how it works. As the money comes into the fund is paying the people who will look after you and me. The doctors, the nurses, the physiotherapists, the dentist, whoever is there, will need to be paid from this fund. The difference from what we have now is that they will pay the same things for you and for me, for the richest person in the country, the president, and the guy who's begging on the corner of the street. If any of us gets what we call appendicitis, this pain that you get and you need to be operated on, it doesn't matter whether you are rich or poor, rural, urban, male, female, you need to have that appendix removed. So the common denominator, the thing that makes us the same, is the illness we have, not whether we have money or whether we're male or female or black or white. And that's where we are working towards. Chair, I don't want to make a very long input because I think the questions are more important. What I want to say to people is these changes are significant. They're big. They cannot happen overnight. So what the bill does, and there's a section towards the end, for those of you who want to look it up, it's in section 57, that deals with the transition period from where we are now to where we want to go. And broadly, it's broken into 2 phases. The first phase is what you are busy with and I am busy with now. 2023 to 2026, we need to get a law in place, and then we need to put the administration, the board, the structures that we need to make the decisions, and to put bank accounts and so forth in place. It will take about 3 years to do that. During that time, we will be developing and improving health services through the budgets that we have. But really, the big changes will start to unfold from about 2026 onwards. And the second phase is supposed to be a period of 3 years where we have the big drive to move the money from how it presently is allocated in the public sector space, in the tax credits, in the road accident fund, in the COIDA, and all over the place where there are many monies that actually should be in one fund so that we all enjoy one benefits. It is going to be a long road. But you have to start every long road with the first step. And that first step is to get the law in place that enables us to do these things. So I want to thank everybody who's been involved, the politicians who have been very hard at work, interrogating us, asking us questions, and you, the members of the community who bear the brunt of sometimes poor service, sometimes suboptimal service, and really we need to do better than we're doing now. This is the starting point. Thank you, Chair.
It's now your time to ask questions and make inputs. I'm starting on my right. If you want to speak or to make a comment, raise your hand now. Oh, Leshap. Number one. Agiriki starter kiakwa. Oh, number one, sir. Number two. You are two. 3. Yes. 4. Yes. Number 5. Yes, 5. Number 6. Komraho, please. If there is no hand, number 7, say, can you please come and stand here? Then later on, they are number 7. Then we've got 7A and 7B and 7C. Doesn't have to work like that. Kupela, all of you, little Emamo, Wakile Atwerim Mike. Can you all come and stand here? Kikupela little Emakamo, so that Likhone will make her input. 3 minutes, ke maximum time. Ya ubulela. Mitsutsu emiraro ne, so that ubulele, and then you can also write. The committee coordinators are compiling the report. Marare rase, akire rara tshwanela re rase ne, please. So, kili nabakam. Let me also take hands this side before others who want to do brainwave are jumping this side and making the queue very long. I'm going to start from here, going backwards, like I did this side. Number 1, yes, hands down. Number 2, any hand? Any hand? Number 3? No, this side, 3. 3, 4, 5. Councillor number 5. Lili na litlo ye makam. Remember your numbers, ne? Yes. Number 1. Remember, Wakile is timing you. So when 3 minutes is over, he will indicate to you. He won't grab the mic. He's a very gentleman. He will just approach you nicely. You can speak now.
Thank you so much. My name is Zonabe Lechayana. I've got a few comments. The first one is on the funding of the bill. The removal of the tax credits, which the end beneficiary of is the person, that is myself as the person who has the medical aid. As well as you talked of surcharge on the personal income tax and payroll tax. Can you please elaborate on those? Secondly, we are currently struggling with unique identifiers within the department. That identifies a patient. There's no linkage between the system of the department and the population register. How then are you going to have unique identifiers to ensure that people do not cheat the system? Thirdly, how different is the NHI going to be compared to the public-private partnerships that we saw happening and fail in the past? And the last one, on the composition of the board, we have seen in many state-owned entities, we have seen ministerial interference, we have seen deployments of people who are not competent, and we have seen money being seen leaving those entities without services being rendered. How is that going to be kept by the NHI bill?
Thank you. Number 2.
Thank you, Chairperson. Dumelang kaofela. My name is Daniel Koka. I'm from Region 2. Chairperson, first of all, we want to raise our dissatisfaction with the time you've given us to prepare ourselves for this comment. However, I'm having a problem with Section 37, Section 38, and Section 39. To my understanding, this fund has everything to do with for the users to buy the services. However, it does not make sense. Why will you have a procurement rules or a procurement arrangement in this fund? Because really, the Department of Health has its own budget. If there's too much demand, the Department of Health can mitigate those demands with their budget. But this budget should actually be about the community. So my question is, when is it going to be about the community? When is it going to be more about the community, less about the business, the people, the tenderpreneurs? That's my first question. And the other issue that I have is Section 4 of the bill, subsection 2. And the Section 4, subsection 2 talks about illegal immigrants. Remember, those guys are here by choice. They're not here by circumstances in their country. They're here by choice. So why will we pay for their what you call this, for their medical bills? We can't do that, even if it's an emergency.
Just a minute. Akere, you must give him chance to speak. Even if you feel excited, can we keep quiet until he finishes? Let us not make noise. If he is raising something you like or you dislike, we must still listen so that those that are taking notes, they are able to write. The inputs is important for Rina as a committee because we are going to reload submit, reload the rumela le haton la lena. So ariska bali le shata. Please let's have patience so that he put all the points nicely for capturing. Thank you.
Don't forget my minutes, Chairperson.
No, you are starting afresh.
All right. Yeah, I was talking about Section 4, subsection 2 of the bill, Chairperson. It talks about the illegal foreigners, illegal immigrants that will be catered for in terms of emergencies. So as South Africans, we cannot find ourselves paying. Remember, the money that is going to be used in this fund is going to be paid by us. So we cannot let ourselves pay for the illegal immigrants. They are here by choice and they need to pay for their services. That's what we are saying. So as a Region 2, we move for subsection 2, Section 4, subsection 2 of the bill to be removed, Chairperson. That's what we're moving for. Section 6 of the bill, Chairperson, is talking to, we request the inclusion because it's talking to the right of the users. As the users, we request the inclusion of the financial statement. We need the report. That report we will like it to be like this way. We like it to be a report from a district level down to the sub-district level. We need to have a quarterly report on that one. So as we can question those misuse of the funds, and also you can question the maladministration of the funds as quick as possible, because you know the corruptions in this country. I've got a minute. Another one, lastly, Chairperson, I'm going to talk to Section 7 of the bill that is talking about composition of the portfolios committee.
More time
More than 30 minutes, Mr. Chairperson.
But I said you start afresh.
30 minutes, Chairperson.
Okay, let me also request, I will give you time, Mara. You were given time and you've got new time. Also, those who have spoken, you can also write and bring the comments to us. You can also continue, and as you conclude, I'm giving you, now is 7 minutes for you. When I speak, leave that one. You can do it later. Can you please leave him to speak?
Well, just to conclude, Chairperson, Section Section 7, that is talking to the composition. I mean, chapter 7 is talking to the composition of the what you call this, the portfolios. But on those portfolios, we don't have we call this, what do you call this? A trustee committee from the ground level. Well, we need to have the trustee committee from the ground level, from the community itself, so as we can be able to question you in those meetings. I thank you, Chairperson.
Thank you very much from Region 2. Can I have number 3? Sorry, Dr. Mkonot, can you go with him somewhere, then you can get what he has, so that you are not disturbing the flow. He has already written inputs. Number 3, sir, come in.
Yes, thank you very much for the opportunity. Mine is not such a long issue and what have you. Mine is just a request.
Libitso, your name, sir?
My name is William.
Thank you.
William Tabata. My request is that I'm very thankful for this NHI, and my hope is that maybe if maybe God can help, that maybe even the board of directors that will be elected or maybe nominated be the rightful people who have got the love of the community at heart, so as they cannot really be corrupt. My main request is that I've got this thing in Afrikaans, so I just need an English copy of a presentation here. Thank you. Thank you.
You can bolela like Afrikaans.
I'm not acquainted to the Afrikaans language. I need an English version of the presentation.
Okay, no, we will provide you. Thank you, sir. Number 4. No, guys, it's in English.
Thank you, Chair. I've been Matlare, Region 2, Ward 8. Firstly, I'd like to extend our sincere gratitude for the NHI, because I think this is what the country has been needing in the health sector all this time. My question is only one. I've heard you mentioning that the service providers will be paid directly by the fund from the NHI. I have fears surrounding that thing, because we know how much our health sector has failed us before. We all know what happens with the PPE scandal during COVID. We all know on almost all sectors that our government is failing us. Why don't we give the funds to a private sector that they can account when there are misuse of the funds, so that maybe they can go to jail? As for you government officials, you have a medical way of getting away with stealing the public funds. So why can't we find a better way that we put individuals who knows that they will account? I was seeing lately in the news, most of the private sector guys, they are going to jail for the corruption activities that they took part on. But government officials, they are still getting away with it. So why are we risking taking it back to the same individuals who have failed us for more than 10 years ago? Why can't we find a better solution, not open a can of worms or give out the money to the vultures who are just waiting there for the opportunity to loot the government? Thank you.
Number 5.
Thank you. My name is Fanki Mamatlodi from Soshanguve Residence Forum. I've got about 2 concerns or 3. The first one is, since the NHI is going to cover a lot of beneficiaries, I had also the inclusion of asylum seekers, foreigners and what have you. So don't you think by so doing it will attract a lot of foreign nationals into our country, and then the expenditure will be more? And then the other thing is, since the NHI will be funded, have you mitigated circumstances where the funding maybe will be exonerated or will be finished by the time the services are requested? We find that they don't have money to fund further activities of the NHI. And then the registration process for the NHI. I would like to know if ever that information will be centralized into a database or not. Thank you.
Number 6.
Thobela. Ke dumedisha ka mo kgorong. Ke dumedisha la ka mo mafuri. Badula stolo. O ka ra ala re theletše. Ke ba ga sekhukhune ba. Bo mma go bona ke ba ga mamogo, ke motlogolo ka ga mamogo. Tate ko ga sekhukhune. Ta swa ke tlaloša, batswadi ba babedi ba. Ke a ba rata ke bona ba go ntiša lefaseng. Ke tlo tsena mo tabeng. Bagolo ba ka. Go na le dilo tše dingwe ga di tsamaye gabotse. Re tlile le batho before ke tlo tsenela ka kwa maphelong mare di tsamaišana le maphelo. Ga ba ja selo batho bale. Ene mola ba phela ka dipilisi sa mathomo. Ba phela ka dipilisi batho bao. O ka se ke wa bolela ka bophelo mara ka mo kwa šia tše dingwe. A re bereke ka mokgwa. A re tsene ka kwa maphelong jwale gape-gape. Le sa gopola ka ngwago mongwe goba kgwedi tše di fetileng. Re dira re bolela le lena. Re go na le batho ba bang ba di-group. That's why batho ba tšhaba go ya ka ditleliniking. Ba tšhabela gore no ba a bolelwa gore ba swere ke malwetši a mabjang. Le sa gopola modula stolo. Ke itše ka ihlaloša nto a ke tsebe gore le tla kae ka tabewe. Le itše la dula bjang gore le kgone go ilokiša. A ke tsebe re lang kwa bagolo baka. Kgombi a kua ga sekhukhune. A ntšhe boloko ka moka. A ka bontša ya hwa.
Sorry. Sorry, Mhlomphegi. Mhlomphegi wa ga sekhukhune. Le ba ba kae lena le sa kry-ang dijo? Oh, Isaac, kupela o attende ntate sekhukhune. I mean, tate wa ga sekhukhune. They don't have food. Number 7, sir.
Good afternoon, and thank you for giving us this opportunity. Thank you for also presenting everything to us. I'm from, my name is Moga Pillay. I'm from Laudium, and I'm here on behalf of the Laudium Senior Citizens Club to get information and to give feedback. We thank you for this. It's a very informative meeting, and I'd like to say that we like this presentation. I think a lot of us were very against the whole idea because we didn't understand it well. So thank you for presenting it. It makes us see, and I definitely see the need for it, for national health. We do need it for everyone, and it makes us feel a bit more comfortable with it. There are, however, a few things. One of the things I'd like to ask, you mentioned that the NHI is not yet to replace or do away with the National Health Act. I'd like to know, you mentioned one thing, that if there is conflict, then the national NHI supersedes the National Health Act. Is that true? So isn't that in conflict or something? Okay, thank you. And then you did mention that there are 4 hospitals in the Gauteng province or Tshwane province that is already compliant. We'd like to just know which 4 this is so that we can follow up on it. My last point is, I think with all of us, we've seen how government cannot deliver basic services. We've seen that with the water, we've seen that with electricity, and why should we trust government to be able to do this successfully? We'd like to know that. What can you do to convince us that it will be done properly? I think previous people have spoken about it also. We've seen when, like during COVID time, somebody else mentioned it, when there is large funds coming in, then we see lots of tenderpreneurs coming in and taking over. We've seen all you've put in place things to monitor and to make sure that there's the minimum corruption. I don't think we'll completely do away with corruption anyway. But how do we know this money is not going to go to entrepreneurs. Thank you.
Thank you. Number 7, we are done this side. Now we are coming to number 1, this side. Can you all please come and stand this side so that we don't have 1.2, 1.1, 1.2. Can you all come? Let them come before you speak. They are coming. They should be 5. What? 5. Yeah. Okay, you can proceed. You all tell us your name and then at least so that we know who we are talking to.
Good afternoon, Honourable Chairperson, members of the Portfolio Committee on Health and Wellness and concerned citizens. I am Tshwane Mostert, delivering this submission on behalf of AfriForum and our 313,000 members, and in particular, our more than 115,000 members in Gauteng. The NHI bill should be rejected in its entirety. AfriForum has reviewed the bill and has found it to be the detriment of healthcare provision in South Africa.
Excuse me, just a minute. We are aware that you are representing AfriForum, but we also request a name, your name, and also be aware that you are only given 3 minutes. Next week, we are having all the stakeholders in the form of your group. All groups are coming. We will try to see if we can give more time, because there are many interests. But just be aware that it's 3 minutes, so don't feel offended. You are going to start from minute 0 because I interrupted you. Wakile, when you see him approaching you, he's timing the watch, because for this one is like that. Thank you. You can start from 0 because I interrupted you. I'm not going to take to say you have already spoken like I did with the other guy, the other side.
No problem. Just to repeat, my name is Tshwane Mostert. The NHI bill should be rejected in its entirety. AfriForum has reviewed the bill and has found it to be the detriment of healthcare provision in South Africa if implemented. Firstly, the government does not have the financial resources to support the NHI scheme, as admitted by the Minister of Finances himself. Neither does the Department of Health possess over the necessary healthcare infrastructure or medical system expertise. Secondly, the bill does not contain enough information on when and how the NHI will be implemented, what it will cost, and who will staff it. It contains several clauses which simply allow the Minister of Health to arbitrarily decide on what the implementation will look like. Thirdly, implementation of the bill will lead to the mass immigration of healthcare professionals from South Africa. A financially and structurally unstable healthcare system will discourage medical experts from practicing in South Africa and incentivize foreign investors to spend their money in other countries. In the last place, it is clear that the NHI proposal is advancing a political agenda and ignoring all budget impact and feasibility studies. AfriForum regards the bill as unconstitutional. The bill and the scheme it represents infringe upon a variety of constitutional rights, including the right to healthcare and the right to freedom of trade, occupation, and profession. AfriForum does not want to criticize without offering any solutions to South Africa's current healthcare challenges. Therefore, the following are suggested instead of passing the bill. A focus must be placed on the repair, maintenance, and improvement of the current healthcare system. Economic growth is necessary to create the financial resources required for the functioning of any health system. Until this goal is achieved, any ideas and schemes are simply distractions from tackling the main problem. The focus should be on deregulation, which will promote healthcare entrepreneurship and create job opportunities. Community-based healthcare solutions stand a better chance of improving healthcare provision than centralized decision-making. The NHI will be an expensive disaster that doesn't actually improve healthcare for South Africans. The majority of available research indicate that the NHI will be a costly and destructive failure. We urge the National Council of Provinces to reject the bill before it leads to the devastation of healthcare in South Africa. Thank you.
Thank you. Can we also have your notes, if possible? you can give them to, yes. Number 2,
Dumelang ba bohle. Hopefully sharp le tswile pele. My name is Fiso Lubisi, ke tlhakela Amaskrala. I volunteer under Youth Desk at Gauteng Police Station. I'm a deputy secretary. So I would like to thank you, health inspectors Katawaya, the NHI. It's a very good thing to the people and the community. So I'm also having a concern because we have an outbreak, cholera. We have an outbreak, cholera. We need to and all that. Learn at least because this cholera thing, this local shops, they are selling things that they are not good to our kids. And it's a serious issue, which we have to attend to. So as the ground forces, it's community and that's community safety. At least let us assisting. I don't know in which way, but there must be a way that we must work together on helping to prevent all those things because they are killing our kids. Thank you very much.
thank you. Urinka NHI bill, re tla isa message ko the relevant officials for that concern. Thank you. Number, every forum, the responses are coming. Why are you leaving? Because you raised issues and we've got Professor Crisp, we've got Dr. Chikovo and Mr. Piti. They are going to give responses and you are leaving. And we are only left with 3 inputs. Is it not really okay for you to also take a message? Because we can't bring speakers and then you raise issues and you leave. The responses are here. Please, Tshwane, we gave you chance, come in, because we are left with only 3 speakers. Please, just wait, proceed, sir.
Thank you very much, Chair. Greetings to the presenters, academics, professors. My name is Matimba Sherimba, coming from the Tshwane. So, firstly, I think.
Matimba, just a minute. Can we please listen? Are you utlweleng hore Matimba o reng? If you want to leave, you don't want to listen to responses, I think you can leave. I was just cautioning you that when you raise issues, there are responses to those issues. It's important to sit and listen. Proceed, Matimba, but let us not make noise.
Thank you very much, Chair. So I think firstly we must applaud the Portfolio Committee of Health in the National Assembly to have came with this kind of ideas. Understanding South Africa that in the whole world, like we are the most unequal country. And here in the country, we've got the Freedom Charter that said that we have to live equal, all of us. So, mine, it will be to compliment, to say that we applaud the particular work. Of course, we understand that there are particular little society that's saying that they are rejecting and so forth, because they believe that they can pay the bills and stuff. But I'm saying that if we're a country that we only have to unite when it comes to our rugby and your soccer. So I'm saying that when it comes to the issue of matter of death, these are serious issues. So we can unite all of us and make sure that we receive a healthcare system which is quality regardless of our standing in the society, particularly understanding where we're coming from. So we are complimenting to say that we are sending the message to that everyone must agree in the thing. To say that as the country or the society, we deserve the things. It's not about who can afford, who cannot afford. So we are saying that everyone must rally behind the thing, regardless they believe that they can afford or whatever the case that it might be in the society. So we are saying that we're actually disappointed about those who are rejecting this particular move. In fact, we are saying that when the parliament sits for them to adopt these things, we urge everyone that must go and vote for the bill
we have understood. I mean, the professor have said that it is going to be a long way. Of course, there will be difficulties there and there. There will be questions of your corruption and whatever those kind of things that we have raised. But where we are, I don't think we need to be predetermined to say that no, this is going to happen. This it won't happen. Therefore, this thing it must be rejected. We are saying no for the issue of society and the issue of everyone being equal in South Africa. The bill it must be implemented with no questioning and with no negotiation. Thank you.
Thank you. Can we have number 4?
Yeah, thanks, Chair. Dumelang. Kalina ke malesela rakabe ke councillor ya Ward 3. I'm just here also to commend the committee for bringing such an opportunity to our people. And just to also simplify what the NHI means to us, because it summarizes the fact that we must be an equal society. During our student activism, we used to say, "Eretwalla campus, strike, tax the rich and fund the poor." And we are here, Repelamo grounding, we can see how unequal we are. If you go to N1, like an accident, others are going to be carried by a helicopter, and others are going to wait for an ambulance for about 4 hours. And we are saying that it's been long since the dawn of democracy. We need to start being equal. We are also requesting that if you go to Parliament, for us to improve services in our public health system, if you go to Parliament and this bill is not passed, we're asking that all public servants, from the president until the last ward committee, cancel the medical aid is one, so that they come to the public hospitals and they're able to change it. So if this bill does not pass, we are giving you that alternative through you, Chair. And we pushing. We're cautious of the fact that the board might have its own issues, but we are totally against the fact that it's the private sector that must control it. There's a narrative that corruption in South Africa has color, or corruption is from the public sector only. People are deliberately forgetting about the Steinhoff. People are deliberately forgetting that white big companies are corrupt. And we're saying that that board, we're going to give it an opportunity. We're glad that it's not going to be the custodians, it's not going to be, we're praising that it's not going to be politicians. But we must also caution society that politicians as well, they are learned in their own way. They are professors in politics, they are doctors in politics, but we are saying that they must shy away from holding public accounts. And if there's any sense of corruption, especially at NHI, we want it to be punished, because more bolela ka maphelo a batho. More are bolela ka wa di kontiri and everything, bolela ka maphelo a batho, that must be taken serious. But in closing, I would like to urge everyone, and I would like the portfolio committee, that in as much as every policy and every project in all the technical glitches, in all the technical glitches, let us solve them, but let's simplify the bill so that our people understand that we want an equal society and we want to get to medical care that everyone is getting, that the Oppenheimers that they are getting, that Mam Keys is getting. Now we deserve it there in Mshongo. Thank you.
Thank you. Number 5.
Oh, thank you very much, Chair. And let me also join my fellow colleagues to welcome the presentation. I'm covered by speakers. I think my 3 minutes will also be reserved. But I want to share with you a painful story, because I'm leading the society that is very disadvantaged. I'm leading a ward that is constituted of 20,000 people, 16,000 registered, deficit of 4,000 influx every day coming to my ward. It's totally informal settlement. But if you are the son or daughter of a rich who never been in a clinic for the whole day and not even getting a communication that says, me as a professional doctor, I'm coming to treat you, and then you'll spend the whole day and coming again another morning without information. You won't relate to these particular problems. So the message I'm trying to drive to is, and I'm lobbying every one of you to support the bill precisely because we are dealing with situation on the ground that is very inhuman. And the integrations of this particular NHI, private sector and public sector, it will actually resolve the challenges that we are receiving every day on the ground. We are losing lives every day on the ground on the basis that we are not having a human resources to aid the situation in the clinics and in the hospitals. But people who have an advantage, people who never suffered before, they will always reject and they will always make sure that we don't get what actually we deserve to get. I'm saying this: if the coffers of the country will be suffered, let it suffer, but being funding a very same a policy that will actually try to resolve the challenges that we are facing on the ground. I'm lobbying every one of you, regardless of color, that let's support this particular bill, because in fact we are speaking about our own lives and our own health, and that will actually aid that particular society. I will end there. Thank you very much. That's it.
Thank you very much, Councillor. I'm now going to ask Mr. Pitsi to respond to issues that were raised, that they are within himself and the province of Gauteng. Over to you. He will be followed by Dr. Chikovo, and I will also give Professor Crisp the last opportunity. We are almost done.
Thanks once more, Chair, and thanks for the questions raised. I think almost all the questions raised are with regards to the bill, and Dr. Chikovu will deal with those issues. But I just want to allay fears that it's not true that public servants, when they engage in acts of corruption, are not being held accountable. And we have seen many examples of that, where people have been disciplined and some have even lost their jobs, and some have been are being pursued by through the justice system to ensure that whatever acts of misconduct and corruption that they were involved in are accounted for in full. And I must allay that those kind of fears that we are all held accountable. No one is above the law, whether in the public service or in the private sector. Thank you very much.
Thank you, Mr. Pitsi. Can I also welcome Dr. Chikovo to perhaps respond to those issues related to the bill?
Thank you very much, Chairperson. Chairperson, I wrote all the questions down, and in the interest of time, whenever we have addressed these sessions and there were questions, we would always send WhatsApp and SMSs to Dr. Tulare Aquina and Prof. Crisp and their team. And I'm thinking in the interest of time, because today we are privileged they are here, I may as well just hand over everything to them. Thank you, Chair.
Okay. Can I welcome Prof. Crisp? And if Dr. Tulare has anything to say, she's also welcomed.
Yeah, Chair, thanks very much. This is why I've tried to sit quietly in the audience and not draw attention to myself, because they actually do know the answers. But since I'm here, I'm happy to address what I can. So the first thing is, the first question asked was about funding. It's a complicated issue, but let me try and simplify it. We spent last year close to 600 billion rand on healthcare in this country. Now that is a lot of money for anybody, and we measure, compared from one country to the other, a percentage of our gross national product, or GDP actually, domestic product. So that's all the money that is spent in the whole country on everything in a year. That amounts to about 8.5% we spend on healthcare. Now that is more than most countries, and it is way more than countries of a similar size and similar economies to our economy. The average of people of our similar economies is about 6.5%. We spend 8.5%. It's very different from the Americans, which some people like to quote, who spend 20% of their GDP, and that amounts to 43% of all the spending in the world was spent by one country last year. So please let's not distort or compare with the Americans and countries in the first world. We need to be comparing apples with apples. We have an economy that we spend a lot of money on healthcare. The problem is that only half of that money is spent in the public sector. 265 billion is spent between the health departments, the Department of Defense, Correctional Services, and the other small amounts within the public sector. The other half, 277 billion, last year was spent in the private sector. Out-of-pocket spending is now gone up to more than 14%. That means your medical aids don't work anymore, so now you have to pay cash on top of your medical aid. The question is, how do we use all that money more efficiently? And the starting point is to find out where are the inefficiencies. And the inefficiencies are by having 9 provinces doing what they want and duplicating one another. We all know it's inefficient. We try to work together. But Section 32 of the bill says, let's work as one system in the public sector. Then in the private sector, we have currently 71 medical schemes. Yes, it's down from 200 to 71. But those 71 medical schemes currently have 308 different options. So how does somebody who's got a medical aid know what they're getting and what they're not getting? And if those of you who watch the newspapers will see that there's a whole big debate at the moment in the public, in the media, about the rates have just been put up for medical schemes by around 9%. Who said they can? The public budget just got cut while the private sector put the rates up. How do we do away with inequity and this waste of money of 308 different options if we don't start pulling together and using all the resources? The resources are also a problem. More than 2/3 of all specialists in this country work in the private sector. How are they going to serve the 85% of you and me who don't go and get our health care there? How's it possible? We need to find ways to pull us all together to use the resources. So the money is in the system. 265 billion is already in taxes. 35 billion is already a tax credit that's given to private people to have medical schemes. 70 billion is already paid for as the public sector towards public sector employees, but through medical aids instead of to the fund. That's already another 100 billion rand. So we don't buy the story. We spend our time studying and understanding where's the money. And most of that money is already in the system. There is money that is spent individually, privately. But once those benefits are being covered by the fund, then instead of paying the money to a private medical scheme for those services, we will pay them to the fund. The only mechanism to do it is by redirecting through tax. And Treasury has a number of tools available for them to do that. The one is to pay that money through the current VAT and personal taxes. The other one is to introduce these possibilities that are raised in the bill of a levy or a payroll tax. So those are matters that are unfolding over time, but we are convinced there's more than enough money in the system. We waste a lot of money. By the way, the funding of the private sector, just the cost of managing the funds is 15%. 9% of the scheme administrations themselves, and another 5.5% to 6% in the practice administrations to administer 72 medical schemes. It's crazy, we're wasting money. The question of unique identifiers. Well, there's already a system implemented. It's in all the public health, primary health care facilities already, and it is in about 25 hospitals at the moment with a unique patient identifier. It's called the HPRS, the Health Patient Registration System, and we have more than 55 million unique IDs already on the system. People who have been coming to services. If you were vaccinated, you're already been in the health service, you've already been on the EVDS, so we already know about you. So that will be the way for us to be able to use that number to be referred between our GP, our clinic, our hospital, to specialists and back again without having to open a new file every time you go. You will open the file with your ID number, and that HPRS number will then open up, and then the provider, the doctor, the nurse, the physio, the pharmacist will be able to open the portion of your file where they are going to add to your record. And that's what's being built at the moment. And by the way, it's a public and private partnership that we are working together and have been for some time. The question was asked about public-private partnership. This is completely different from public-private partnerships. This is us all together acknowledging all the resources must be accessible to all of us. That's what we want. If I'm living here in Pretoria, for instance, and I go on holiday and I go to a place where I'm not in my familiar territory and I get sick, I must be able to go and see the nearest provider where I am and be cared for. My care must be recorded onto the system so that when I get back to where I live, my diabetes or my HIV or my TB or whatever it was that was treated can be captured in my file. There's often this question about boards and SOEs. So for those who like to quote these, there are 22 SOEs in South Africa, 22. They are listed in Schedule 2 as part of the Public Finance Management Act. They are big companies, massive companies, Denel, Transnet, Eskom, etc. There are 157 public entities over and above those 22. And those are just the national ones. 5 of them are controlled by the National Department of Health and report to the National Minister and through the National Minister to Parliament. They've just reported in the past week. That's how they work. And do we hear you all complaining about those 157 public entities, all the regulators and so on? How many of them got clean audits and how many of them got unqualified audits and so on? So we must be very careful of taking something that looks like Eskom or Transnet and saying, therefore, we've got a crystal ball, we can see you're going to mess up something else that is not even one of these. It's like a difference between a listed company and a private PTY limited company. They're completely different things. Often the question is raised about foreigners. So the story is that our country is part of the world. We cannot be in an island. So we have signed agreements as a country in the United Nations for looking after children, for dealing with people who are run away from war zones and economic hardships and so on. Those are agreements, and in those agreements, part of it is that we will care for those people. Once they're in this country and they are spending money on taxi fares and buying things, they are already paying tax, they're already paying VAT, they're already paying contributions to the petrol levy. So those people, even if they earn little, that are in our country are protected by international law. The challenge is people who are illegally here. But we are health practitioners. It's like a mother will never turn her back on a child, even if it's not her child. As health practitioners, I can't walk away from somebody who has got a health problem. But what we are saying is, we will look after the emergencies for people who are illegally here, and we will look after all children. And we will also look after any condition that somebody has that will infect our population, such as COVID, TB, etc. So that does not mean that we don't need the cooperation of Home Affairs and the police and the border management and so on to improve the management of our borders. But that's not our problem as doctors and nurses. There was a question about user rights, but I didn't quite get it. The point about Section 6 and user rights is that the fund is designed to be transparent. What does that mean? It means no secrets from you. It means when we tell you that these are the benefits covered, you must be able to see that these are the benefits covered. If we tell you that this is where you can go for healthcare, there must be a list. It can't be, hey, there's a separate list for us and there's a separate list for them and this one is designated and that one's not designated. It must be open and transparent. And in Section 6, it also says your record of your healthcare belongs to you, not to the doctor, not to the hospital, not to the state. It belongs to you. But the practitioners must be able to contribute to your record. About the board. So all boards of all public entities report to Parliament. but they all report through ministers. The ones that don't, like the SABC, which is appointed by Parliament, is been seriously problematic. Because how do you get a parliament of over 400 people to elect or nominate a board? So the Constitution in section 92 of the Constitution says that the President holds a minister responsible for their functions. The minister has pieces of legislation. We have about 30 in the health sector. And those pieces of legislation, the minister must manage them. But the minister is held accountable by cabinet and parliament. So if the minister appoints a board, and you will see the amendments in section, I think it's section 12, that says the minister must get the approval of the cabinet to appoint the board. And that was because the Portfolio Committee in the National Assembly heard the complaints about what was in the initial bill and said, yeah, we agree with you. We think we need to have another check and balance in the process. So the question was asked, what about ground level members? In the intention of the bill, and what we will explain clearly in the regulations that we are busy drafting, which obviously we can't publish until there's an act, will be that everybody, each of you, anybody in this room, anybody in the country who is legally here can nominate somebody to the board. And we want community groups to nominate people. But if you're going to be managing 3, 4, 500 billion rand down the line, you want people who are lawyers and accountants and people who you trust to be there. You must make sure that you nominate people that you trust to be there. Yes, I also pray the directors work for the people. That will be my greatest joy. So the question about service providers being paid directly and the PPE scandals and corruption, I'm glad that the honourable councillors gave an indication that corruption is not unique to the public sector. We have more corruption in the public sector and more fraud in the private sector. And we reckon that there is somewhere, we've seen reports that reckon that there's somewhere in the order of 19 billion rand a year fraud in the medical schemes environment. It's easy to do fraud in the private sector, very simple. And the President put together a forum of all the law enforcement agencies, public and private providers and funders to interrogate why and where this fraud and corruption is taking place. It's frightening. It's become a disease for our country, but it is not unique to the public sector. What we need to do as citizens, as people who live in this country, you and me, is make noise. If we see things that are wrong, we must raise our voices and we must fix these things. It's not to say we mustn't do something because there's corruption. We must get rid of corruption. So there's a question about the National Health Act not being repealed. So the National Health Act is still the biggest act, and it covers the provision of healthcare. The amendments, the two main amendments to the National Health Act that are brought about by the National Health Insurance Bill is Section 32, which changes the functions of the province, and it makes the province responsible for what we call stewardship, the overall oversight of the entire health system. So instead of being the public health department, they will be held accountable for the whole public and private sector, everything that happens in healthcare, and they will be held responsible for liaising with all the other government departments for what we call social determinants of health. So that's water quality, air quality, road traffic management, safety and security, etc. Because all the people who suffer from failures in those systems end up in a hospital somehow with a gunshot wound or a traffic accident or bad lungs or whatever the case might be. So that's the one change. The other change is the change in Section 36, which deals with the districts. To decentralize the districts, there are also some changes to give more autonomy to the management of public hospitals. Those are the main changes in the National Health Act. If there's a conflict, if there's a challenge in a court, what the bill says is that the NHI bill will supersede any conflict that may arise. So I think to Tshwane and AfriForum's comments, well, we're aware that you have concerns. You've raised them with us before about funding and infrastructure and personnel and so on. We're also concerned about those. That's common course, that there are problems with infrastructure, there's problems with personnel and so on. But part of the problem is having 2/3 of all your specialists sitting in the private sector and having a dermatologist seeing someone with scabies that my mother could treat without being any qualified at all, and having people going directly to an obstetrician and gynecologist when they could have seen their GP. Those are the problems. We are abusing our specialists and abusing our professionals. And if we are able to move patients to where a perfectly well-qualified nursing sister can look after somebody's health care and then refer them to a GP, and the GP refers them to a specialist, we will have a far better system. The infrastructure problem is well known. It has run down over a long period of time. But when we get told, fix the infrastructure, we say, sure, give us another 100 billion rand. Where are you going to get it? Raise the taxes. Now, forget about NHI, just give us more taxes. Clearly that's not going to happen. That's not viable. So the answer is to say there are 265 perfectly adequate private hospitals in this country and over 100 day hospitals in this country, some of which are 30% occupied. Why don't we use them? Why can't the people of Diepsloot be referred to the Life Fourways Hospital instead of to Charlotte Matseke? Why not? Why can't we as the fund buy that healthcare from the nearest hospital, not the 3rd or 4th hospital on a long taxi ride for a poor person? That's what the fund will do. There are perfectly well-qualified practitioners in those hospitals. They trained in the same institutions we did, same universities, same everything. But we make it not accessible because of money. So the fund's objective is to say, remove this common denominator problem of money and pool our money and let us buy the healthcare from the most appropriate general practitioner, clinic, pharmacy, optometrist, and hospital. So that's what we are trying to do. If that's going to chase investors out of the country, I think, well, that's not what I hear. And I was with the Swiss Chamber this week. I'm with RMB the other day. I've been with all the investment houses, all the banks, including foreign banks. It's not what they're telling me. So I'm not that convinced that that's going to be a problem. And mass immigration, I'm fascinated by this mass immigration. So I've been privileged to work or study or examine 29 different countries, 7 in Africa and a whole lot of countries around the world. And nearly all of them have already got a national health insurance. So if our doctors are going to leave and go to Australia, New Zealand, Canada, they're going straight into a national health insurance system. They'll be told where to practice, how to practice, what to prescribe, what the standard treatment guidelines are, because that's how it works in those countries. So I don't think the NHI is what will chase people away. And by the way, we are told we've got one of the most well-paid health systems in the world. We are the 4th highest paid public service in the world as well. So the problems are different problems, not those ones. We don't think it'll be an expensive disaster. We think it'll be a far better system than we have now, but we are very happy to discuss and debate that. So for the chair, I'll end off by saying to the honourable councillors, the issue, you are quite right. You work closer to communities and closer to the ground than we do. And we like to listen. That's part of the purpose of coming to this meeting today, is to listen and understand what is on people's mind. We know people are unhappy with the health system. But people who use private sector are as unhappy as people who use the public health sector for different reasons. And we are listening carefully to why are your communities unhappy. And we believe that even if it's a long road, we cannot continue with a society where we just perpetuate inequity and we perpetuate unhappiness and waste of resources. It can't continue to be like that, and we will definitely agree with you. We will not tolerate corruption. We agree with you that we would like to see everybody comfortable to use public health facilities as much as private health facilities, and we do need to make sure that we simplify the way we convey this information to you. Chair, I think I've covered all the questions. Thank you.
Thank you very much, Prof, for clarity to the questions that were raised. We appreciate it very much on behalf of the population. I'm going to give a small chance to the permanent delegate, Honorable Bacha, to also say something here. You are welcome, sir.
Molweni. I think mine is more to be part of these meetings, to get a sense of what people are saying to Gauteng province. In the end, what you say here is what will be said by the province when we get back to the National Council of Provinces. I think you might have heard that the National Assembly has already accepted this bill. It went through, and now it's with us in the NCOP. Hence, these consultations that are done in Gauteng province and other provinces nationally. So mine is more to appreciate the fact that we've had so many public meetings, and these were additional to what was planned, because I guess it was more to get to more people than we already had, to get a sense of what it is that people want to see out of our health system. And what we will take back to the National Council of Provinces is what we get from you. And so I want to appreciate, Chairperson, the fact that this consultation, some people might see it as meaningless or not carrying much weight, but it really carries a lot of weight, because when I stand up and read what Gauteng province is saying about the national health insurance, it will be something that I've witnessed, it will be something that I've been part of as well, for the bill either to be passed or not to be passed. But I guess I have a sense of what Gauteng people are saying about this bill. So Chairperson, in so few words, I just want to thank people for coming out, giving us their views on what they see or how they feel about the bill, and that's what I would carry to the National Council of Provinces, obviously after being instructed by the provincial government of Gauteng. So I want to thank you all for your participation, and I want to thank you, Chairperson, for your commitment to this process. It's been long, but I think that it's worth it. Thank you so much.
Thank you. Thank you very much, Honorable Bacha, for those words. We have come to the end of our meeting, and thank you for coming. Clap hands for yourselves. The community wishes to see the NHI bill move to the next level. That's what the people are saying here. So I thank you, because you raised your concerns, and we, as the committee coordinators, we've compiled a report. Continue to write your submissions and give them to us. You can also email them. In our advert, there is already an email. So I want to thank Councillor Pasha, Councillor Rakabe, and Councillor Liwele, and any other councillor who is here that I did not see, for being part of this meeting. Thank you to the committee, Gauteng Portfolio Committee of Health and Wellness, Member Litsie for being here, Member Bacha from Parliament, NCOP. We thank you very much. So, and thank you to all of you for being part of this meeting and come and give input. I thank you. Clap hands for yourself again. I also want to thank Mr. Piti and Professor Chikovo, Dr. Chikovo, the professor in making, and Professor Chris for those, please, you officials, hello, what are you doing? You are disrespecting this meeting. Can you please sit down? These people, they are not going to steal those things. They know they belong to you and you use them all the time, wherever you go. I've already told the meeting where they stay here. Please, do not do this. We are on time, we are keeping time, everything intact. You are now misbehaving there. Please, don't do that. So, you must not do that until you are instructed to do that. So, for the presentations that we received, we thank you very much, and for the clarity that you have given to this population here, we appreciate it very much. So, we're looking forward to see you again. We are having the last public participation next week in Westrand. So we will also meet with the rest of the members there so that we conclude as Gauteng. Because of the support that you are giving, we had to open an extra opportunity for this meeting like this one. So I want to thank all the officials that took their time to come and be with us, and we appreciate it very much. Now, the food is going to be given to you seated here. Do not move. Those that are in hurry, I'm very sorry that I brought you back. You are free to can exit, but everyone sitting here, please, can you sit down? They are going to give you something to eat while you are seated, because if you, or they will instruct you, but please don't make a commotion. We appreciate you very much, and we say safe travel to your respective homes. It's Friday, travel safely. Thank you very much. The meeting is done. Thank you, Chair. Batadi akisaba bulelezi bathwenya kere. This thing. Are ujaba skata raba. Are etela kopini.